I think it is. I think that, you know, the plan in the House, and, you know, we haven't really seen anything out of Senate Finance, but we've seen something out of the other committee, the Health Committee in the Senate, and in both cases, these plans would cover most people who are uninsured. There would remain some groups, a third of the people that they found that would remain uninsured are people who just decide they still don't want to be covered. A third would be people who are eligible but not enrolled in public, and a third would be immigrants who are not eligible, undocumented immigrants. But for the most part, the vast majority of that 47 million plus now with the recession would be able to get coverage. So it's certainly possible to create the structure. I think the challenge that we're seeing now is figuring out how we come up with a combination of cost containment measures to decrease costs in the system, create savings, and increased revenues to pay for the plan that we have, the plans that we have on the table.
Mm-hmm. Well, you know, what we're experiencing more and more is that insurance companies will only cover a certain amount, and they only allow physicians to order a certain amount. And you would think that the costs would come down if they stay within these parameters, but the cost has not been contained. So what is the approach to that? Can we ensure that some of the costs will be contained? When a person needs an MRI and they need a follow-up perhaps, the insurance company will not pay for a follow-up. Often when doctors prescribe certain medications, they cannot prescribe it over a certain number of days. So the direction is wholly within the insurance company. So often patients don't get what they really would get from the decision of their physicians because it's not covered by the insurance. Now, will that make this any different? Will they still be, insurance companies still will be rationing and still charging more?
Well, I think what you've put your finger on is sort of the fallacy in this argument against health reform, which is that government will ration care. I mean, as you say, that's going on every day now as insurers make decisions. Stepping back a little, I think that the cost containment ideas that are on the table now really will make a difference and allow people to get the care that they and their doctors think they need. I think in large part what will happen is would change the way that providers get paid so that we can pay for quality, not quantity. So that's a very large part. I think when we talk about healthcare reform, we often focus on coverage, but the real goal, and I think President Obama has made this clear, is that there's three goals: decreasing costs, increasing quality, and getting people covered. And I think those are all equally important. The decreasing costs is difficult because it means that some people may end up getting less revenue in the system than they get now. And that's what we've seen in a lot of the pushback. But I think, you know, that's really where we are now, is to come up with these ways to pay for quality instead of quantity by changing payment mechanisms, and at the same time honoring that relationship between the patient and the doctor so that that can be the primary focus.
Why do you think it's so difficult to get the cost of health care under control? Because there are so many people that are poor that do not even have health insurance, but the cost continues to go up for those that do have it, and with less coverage. And that seems to me that the manipulation is coming with the insurance companies, since they do a one-size-fits-all. They only pay for one this and one that, and whether a follow-up is needed or not. Will that change under the...
Yes, and I think that's one of the things that, you know, we really need to get more attention on, that, you know, while this is for people who are uninsured, it also is for people who are insured, who have seen over time their co-payments go up, their deductibles go up, where they've had to fear that their employers are going to drop their coverage, or they can't leave a job for a new job because they're locked into their current plan and afraid they won't get it elsewhere. So I think that's really a key part. How do we, bring down, we're never going to decrease the cost from year to year, but we want to decrease that rate of increase, bend the cost curve, as President Obama has said. And I think there are a number of alternatives on the table that will do that, because we've seen places where, particularly in Medicare, where they are paying less for care for Medicare beneficiaries, but getting more quality than other places that are paying higher costs and less, and their outcomes are not as good. And I think that's where a lot of the proposals like bundling payments for hospitals, I don't want to get overly technical, but I think this is an interesting one, because what this would do is say to hospitals, we're going to pay you a fee that's going to encompass not only this hospital stay, but if somebody needs to come back, say they got an infection while they were in the hospital and they have to return for within a short period of time, your payment's going to go for that as well. So it realigns the incentives to get it right the first time, and to make sure that people are focusing on the right things. I mean, hospital-acquired infections, there's clear evidence that some very, very simple steps can be taken to limit the number of hospital-acquired infections, which end up costing large amounts as people have to remain in the hospital. Not paying for those. I mean, Medicare and Medicaid programs are beginning to say, we're just not going to pay for those anymore. So those are the kinds of things that I think can bring down costs over time.
Well, and I've heard that there are people who think we're going to be putting together a big free system. I don't see that. As a matter of fact, I have been making it very clear that I think everyone ought to pay according to maybe a sliding scale, but ought to pay for health care.
I think that's right, and I think the House bill certainly has a system of subsidies that are, what I think is particularly good about those subsidies is that they focus not only on the premiums that people pay, the cost of coverage, but they also protect people for excessive out-of-pocket costs. And in both cases, these are sliding scale. So people at the lowest end of the income scale pay something, but they pay less than people as you move up the income scale, and it eventually sort of taps out, and then people are on their own. I mean, in this new system, everybody will have to have coverage, so there is a responsibility to make sure that there's affordable options for people so that they can meet that new individual responsibility requirement, but at the same time, you want to set it up so that people do have a responsibility to contribute to the extent they can.
And the offering of primary care, preventive type care, I think it ought to be some individual responsibility, required responsibility, when they teach people what they can do for themselves to control their illnesses. And I believe that is provided for in the bill. There'll be teaching of how to take care of a wound, or when to get a child to the hospital and not just use emergency rooms for areas that could have been prevented before you get to that part. And that is the part that I have lots of questions about from my area in Texas, because we do have a lot of immigrants who are not citizens, and they traditionally use the emergency room for care. But each time I hear someone talk about this plan, they say a plan for all Americans. So how do we approach that need?
Well, I think there